Welcome to Trauma Informed Care for Perinatal Care Teams. I'm Lisa Kirkland. I am a California Registered Associate Marriage and Family Therapist, and I specialize in working with individuals, groups, and organizations to understand, address, and improve perinatal mental health and well-being. So let's look at our overview for today. We're going to take a look at trauma-informed care, also known in the literature as a trauma or a TIC framework. We're going to look at why trauma-informed care is important. We're going to look at some action steps that care providers can take, and we're also going to look at the difference between trauma-informed care versus a trauma-informed system. Okay, so here we'll just get into the introduction of what trauma-informed care is. It's a framework that recognizes the effect that past trauma can have on current behavior and one's ability to cope. Trauma-informed care responds by integrating knowledge, including signs, symptoms, and responses of trauma survivors, in a comprehensive way in its service delivery. Trauma-informed care takes place when services are based on an understanding of the vulnerabilities of trauma survivors in order to be more supportive and avoid re-traumatization during healthcare encounters. So here are the key concepts of trauma-informed care. We have the 3 E's, 4 R's, and 6 principles. So the 3 E's is really the conceptualization of what trauma is. So trauma-informed care understands that individual trauma results from 3 things. The first is the event or series of events or a set of circumstances. And then that those events or circumstances are experienced by an individual as physically or emotionally harmful or life-threatening. And that this event, along with the experience of the event, has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So that's sort of how we conceptualize what trauma is. It's the combination of the event, the experience of the event, and the effects that it has. The 4 R's are also known as the 4 assumptions. So the 4 R's or 4 assumptions are that clinicians will show sensitivity by realizing and normalizing past trauma. They will recognize their patient's behavior as a coping mechanism. They will respond by creating safer environments, and they will seek to avoid re-traumatization. And all trauma-informed care is based on these 6 principles, which is safety, trustworthiness, collaboration, peer support, empowerment, and cultural sensitivity. We'll look at the clinical applications of these principles, as well as the 3 E's and 4 R's, in a perinatal care setting a little later in this presentation. So let's get into why trauma-informed care is important in perinatal care. So the Substance Abuse and Mental Health Services Service Administration has a report called The Concept of Trauma and Guidance for Trauma-Informed Approach. And in this report, they found that medical services can reawaken past traumas. This report also describes how people with previous trauma are more likely to respond to new traumas in a heightened manner, and that people can bring in coping mechanisms from early trauma to their current healthcare situations, which seem out of proportion and tend to no longer be adaptive. So it's also been found that there are some populations that are a bit higher risk for reawakening these past traumas, and these are women, especially the unhoused, incarcerated, or substance users, refugees, those that have higher adverse childhood experiences, childhood maltreatment and abuse, sexual assault survivors, previous traumatic birth experiences, and members of cultures with historical trauma. And here I just want to make a quick note about historical trauma. It's a term that is used often, but doesn't really get explained well. So I just want to make sure that we take just a minute just to check in on that. So historical trauma is the cumulative, multi-generational, and collective experience of emotional and psychological injury in communities and in descendants. So what that means is cumulative, right? It builds on itself. Multi-generational, it gets handed down from generation to generation to generation, as well as collective. So what that means is that a person or a family may not have themselves experienced trauma, but because of the amount of traumatization within that community, the entire collective community has experienced it. So a really good example of, well, not good example, but one of the most familiar examples of historical trauma is that which has been experienced by Native Americans. This includes events such as forced relocation, genocide, or abduction of their youth and sent to more than 350 government-funded boarding schools. So just want to make sure that we have a good understanding of what historical trauma really is. Trauma-informed care recognizes that anyone can be a trauma survivor. So that would mean that clinicians and practitioners and providers should use trauma-informed care with all pregnant and birthing women and people, regardless of whether the women or birthing person has a known history of trauma. Let's look at some of the benefits of trauma-informed care, especially in the perinatal setting. So we know that by applying the principles as well as the assumptions and the understanding of trauma, that in the perinatal setting, there's improved interpersonal interactions that reduce experiencing symptoms. It also creates a safer environment, which allows for the vulnerability and dependence on caregivers that the perinatal period requires. Trauma-informed care encourages identification of individual triggers instead of just general or generic ideas of triggers. It also reduces intrusive physical contact and the use of invasive or unnecessary procedures that can be re-traumatizing. Trauma-informed care improves perinatal emotional well-being, which affects bonding, breastfeeding, and healthy attachments. And it can also result in empowering and healing experiences for the woman or birthing person. So let's look at some action steps for perinatal care providers that they can take. So the first would be being able to recognize trauma, including its signs, symptoms, and responses. So by knowing these signs, symptoms, and responses, care providers can begin to see that patients' behavior is more of a trauma response or coping mechanism, thereby increasing the provider's compassion and patience, especially for more challenging patients who could most benefit from trauma-informed care. So let's take a look at some of these. We've got 3 different columns here. So the first is hyperarousal, which is what we would typically hear people talk about is the fight, flight, or freeze response. Here you would notice angry outbursts, fear or startle reflex, out of proportion responses, so a response that doesn't seem to match the level of intensity of maybe the situation, emotional overwhelm or panic, tight muscles, and just that frozen deer in headlights kind of response. Now, hypoarousal is the other end of the spectrum. This is where the nervous system is shutting down or collapsing. And here we would notice depression, people with a feeling of numbness or emptiness, a flaccid body. You'll oftentimes notice a blank stare. an inability to speak or make decisions, and then dissociation. And some other effects of trauma can be low self-esteem. We often see substance misuse, trouble concentrating, a decreased ability to attend to body cues, which we can see would be very important in the perinatal setting, especially with labor and delivery and breastfeeding. Mistrust of providers. We can often see this in communities that have had higher levels of historical trauma, as well as flashbacks, sleep difficulties, avoidance, and suicidal ideation. Okay, so let's look at the 6 principles in the perinatal care setting. So first we have safety. So safety can be in the environment, also known as sanctuary. So a safe environment is one in which a sense of psychological and physical safety can be established. So this trauma-informed environment in the literature is often referred to as sanctuary. We can also encourage the feeling of safety by maximizing feelings of our patients being supported, listened to, and in control of what is done to them, and minimizing any feelings of being alone, disrespected, or experiencing excessive pain. The second principle would be trustworthiness. So here the care provider can become a representation of a secure attachment figure. Some behaviors that the provider could demonstrate would be a warm, nurturing, and attentive sort of disposition. They would be attuned to the needs and fears of their patients. And most importantly, they're reliable in their words and actions. This can be achieved in the perinatal care setting by active listening. So listening, reflecting what's been heard, asking for clarification when needed. Informed and dynamic consent. So what this means is that the care provider continues to gain or verify consent throughout the encounter, as well as developing their competency in their training and knowledge of trauma-specific interventions. The third one is collaboration. So first we would collaborate with patients. So we would involve patients and their families in the treatment process. Then we would encourage mutual collaboration. So this is where healthcare professionals assume complementary roles and cooperatively work together, leading to continued improvement in decision-making and the formulation and execution of plans for patient care. And then we also want to make sure that we're engaging trauma-informed care referral sources. So by collaborating professionally and with outside departments or organizations, we're able to establish whether or not that referral source is trauma-informed. And if not, making sure that we are finding those referral sources. The fourth one is peer support. So peer support could be in the form of doulas, both birth and postpartum. And then we would want to normalize the attendance of family and friends at appointments, as well as encouraging involvement with community groups and organizations as an expanded support system. Fifth is empowerment. So in a trauma-informed care approach, we use the individual's strengths in the development of care and treatment plans. We encourage patient self-advocacy, and trauma-informed providers hold hope for healing experiences for their patients. And then number 6 is cultural sensitivity. So we want to make sure that we learn about traditional responses, cultural practices, and protective factors of the groups that we serve. We also want to collaborate with community leaders. By collaborating with community leaders, it allows us to build trusting relationships, to understand the unique needs of the community, and to better recognize the many strengths that are within the community as well. Also, checking in with community leaders and organizations helps to inform the language that we use in any of our activities or programs that we are putting together for patients. Okay. So with an understanding of trauma-informed care, right, the 3 E's, the 4 assumptions, and then the 6 principles that go into all aspects of it, we can start to look at some specific trauma-informed interventions. Now, it's important to note that there are very few trauma-informed models or trauma-specific interventions that have been developed and tested for pregnant and postpartum women and people. Collaborations to build an evidence base are definitely needed. So what we're going to go through is a few different themes that are often noted in the literature for areas where there are fears or struggles for people who are pregnant or about to give birth, or postpartum as well. So the first one is need for control. So an easy way to help out our clients in a trauma-informed way is to explain what to expect. So explain what to expect in an appointment, explain what to expect from an intervention or procedure, as well as what to expect afterwards. We're always going to ask permission before touching. Whenever possible, we're going to make eye contact and sit down when we're communicating. And then a last area where the patient can exercise some control is by creating different plans or scenarios for themselves. So for example, a patient could put together a birth plan or birth scenario, which might include for scenario A, which is a smooth, uncomplicated labor, as well as planning for scenario B, which might be a situation that has unexpected twists that make intervention necessary. Then we look at the theme of difficulties with disclosure. So first way to have a trauma-informed intervention would just be to make sure that the patient encounters materials that normalize adverse experiences. This could be routinely using screening measures, so every patient gets screened, having hotline numbers or support groups posted for any kind of adverse or traumatic experience support. Here I just listed a few of the available screening measures for trauma, which is the ACEs, the Adverse Childhood Experiences Questionnaire. We have the practitioner guided post-traumatic stress disorder 5-question questionnaire, as well as the once there's a screen that comes up positive for that, we can move over to the PCL5. And most of those are available through, well, the ACEs is through Kaiser, and then the other 2 are through the Veterans Administration. And then we also want to make sure that we have trauma-informed care referral sources ready. So the reason for all of these sort of steps here is because we know that women won't disclose in a clinical setting unless they know that the providers are competent to hear their disclosure, that they won't be judged for their disclosure, and that some form of help is available. Then the next would be is if we have a patient who is struggling with dissociation. So dissociation generally has two different forms. One is depersonalization. That's sort of observing what's happening to the body, not really feeling connected to the body. So a way to work with patients that are experiencing depersonalization is to help them get back into their body. So 2 of the easiest ones that I use often is to have them hold ice. They can hold it in their hand, they can hold it in their mouth, and just see how long they can sort of tolerate that. And it helps really ground them back into their body. And then you can also have them touch different items and describe the texture and sensation, weight, anything like that. And then derealization is when they feel sort of outside of reality, like it's what's happening isn't real, or it's almost like a dreamlike state. So you want to get them back to the present moment. One of the ways you can do that is by playing catch. That's a super grounding, like present moment grounding activity. You really have to pay attention to the back and forth. as well as doing 5 senses exercises, which would be naming 5 things you see, so using the eyes, touching 3 things, so that's the tactile, listening for 2 sounds, as well as noticing maybe the taste in the mouth. So we can also look at a theme of discomfort with vulnerability, which especially during labor and delivery is a really important aspect of that process. So we want to make sure that we prioritize building rapport and trust. And then we want to be able to recognize behaviors such as avoidance and difficulty regulating emotions as trauma responses. Relationship is key. So being able to recognize behaviors such as avoidance or substance use or difficulty regulating emotions as trauma responses can really improve interpersonal interactions, which help with the discomfort with vulnerability as well as with difficulties with disclosure. And then we'll move to the last, which is coping with remembering, which can also be termed in the literature as re-experiencing. So if you have a patient who's coping with remembering past trauma, the very first step is to reassure the patient that they're safe and to maybe even have them articulate that as well, even if they don't feel it, having them start to reconnect with the present moment that they are in fact safe. You also want to make sure that there's continuous companionship, reassurance, and kind treatment. And this is really important, especially during labor and delivery, if the patient receives like epidural pain management, because the absence of pain doesn't necessarily mean the absence of suffering. So we want to make sure that somebody is there to offer this companionship, the reassurance, the kind treatment. And this can easily be achieved by making doula support available for patients. And then as care providers, we need to be ready to alter our routines and be able to respond therapeutically to our patients in the moment or at the bedside. So this one, the being able to respond therapeutically in the moment is something that requires both training as well as a system that supports care providers in being able to address their own trauma histories and any vicarious trauma that they might experience. So here we're going to look at a case illustration, which will bring in an example of the 3 E's, the specific effects of trauma in childbearing, and the utilization of the 4 R's. So we'll start just with the event and get us started. So the event is we have Josie as a patient. Josie's mother had a string of violent relationships, drank heavily, and failed to protect her daughter, Josie, from beatings. So we know after the event comes the experience of the event. So when we're talking with Josie, when we're taking that medical and psychosocial history, we find that Josie felt abandoned and believed that she was alone in the world, unworthy of love, and she was often depressed. The effect of this traumatic experience was that she has spent the last 3 years herself in a violent partner relationship. And so when we look at the effects specific to childbearing, we have Josie presenting to her midwife, explaining that she's worried that she will not feel love for her baby, as a feeling, and has a feeling of panic that she'll not be able to keep her own baby and child safe. So here we have our 3 E's, the effects specific to childbearing, and now we're going to look at the way that the provider, the midwife, can utilize the 4 R's in the treatment and care of this patient. So first, the midwife responds by acknowledging and providing education on cycles of abuse. The midwife will hold out hope that Josie will bond well and choose safety for her baby. She also connects Josie to intimate partner violence services that also provide parenting support and education. The midwife resists re-traumatizing by anticipating Josie's need not to feel abandoned. She arranges a doula so Josie will have continuous support in labor and the subsequent days thereafter. So that's just one illustration, one example of how to use trauma-informed care in a perinatal situation. So lastly, I just wanted to touch on this really quickly, just like I had mentioned before, that to be able to provide this kind of care, most often we need to be working within a system that also is trauma-informed. So let's just look at the differences between the two, and then we'll kind of see a little bit more clearly why that is. So if you are a provider that is utilizing trauma-informed care as an approach, it's an individual approach. It's usually just you or maybe a few of your colleagues. There's limited financial, professional, and community resources for providers and patients. There's also when trauma-informed care is an individual provider's approach, there's limited mental and emotional support for both the provider and for the patients. This often leads to compassion fatigue, re-experiencing of personal trauma history, vicarious traumatization, and burnout. So if we look at what a trauma-informed system is, it is a place where trauma-informed care is organization-wide. This means that all staff from the front desk to the medical providers understand and implement the 3 E's, 4 R's, and 6 key principles. Within a trauma-informed system, there's consistent training, screening, and referral routines that are part of the policies and procedures throughout the entire organization. So the staff and patients both experience the healthcare context as a safe, supportive environment. And a trauma-informed care approach requires staff to support each other when there are challenging clients or adverse outcomes, which can improve the mental health and well-being of both providers and patients. So in summary, providing trauma-informed care as part of the perinatal care has the potential to prevent adverse outcomes, to help break cycles of mental health disorders, and to change the parent and child's lifespan trajectories in a positive direction. The main takeaway of trauma-informed care is this actionable step: changing the paradigm from what's wrong with you to what has happened to you. Oh, excuse me. Here are our references if you want to look into this a little bit more. And here's my contact information if you would like to reach out. Please feel free. Thank you for attending the Trauma-Informed Care for Perinatal Care Teams, and I look forward to hearing from you. Thanks.